Yeah, I entered, after my fellowship, Dr. J. Forrest hired me as an assistant professor. Now, first I did a fellowship in obstetric anesthesia, and I was going to go to Winston-Salem to do this, but the logistics of bringing 3 children, I was a single mom by that time and had been throughout my residency program. It was very difficult to do that. So I worked at McMaster with Dr. Molly Towell, who did the research on placental transfer of drugs. We went to Guelph on a regular basis and worked for the animal model of sheep fetuses. And so I did that until Dr. Forrest decided that it was time to offer me a full-time job, which was 3 months into my fellowship. And I was then offered an assistant professor position, an academic position at McMaster in 1981, in the spring of 1981. Well, you may know that I've spent about 20 years working on women's issues in medicine, and that's been an interest of mine. I think we've come a long way. I think back in the 70s, it was very difficult, whether you were in anesthesia or any other specialty, to combine having a family. There were no real rules and regulations about call. I mean, when I was at St. Joseph's Hospital, I was working 1 in 2 on call. We started off 1 in 4, then somebody dropped out, then it was 1 in 3, then somebody dropped out, it was 1 in 2. It was very difficult to work around those schedules. I think with time, the organizations such as CARE and PERIL have done a lot to make it possible to have a family, not just for the women, but for the men as well. Times have changed. The hours are more organized. There are rules about things like maternity leave and so on. And I think anesthesia really isn't all that different from many of the other specialties in that respect. I don't think people realize the kind of hours you put in anesthesia and how hard it is physically to work in the operating rooms. On the other hand, we do and we did have day off after call. Now, my pet peeve has always been that it's not particularly wise to do 24-hour calls for anybody, but at least we had the next day off. I think that over time, we have realized that people work better if they have regular hours. They are happier in their work if they have a happy home life, and if they have other interests. I think they make for better doctors. And I think that applies to anesthesia as well as to all other physicians, and I think we're moving in that direction. But it certainly didn't exist in my days. Well, I think I chaired the first Women's Issues Committee of the Ontario Medical Association. We started around 1986 or thereabouts, and at that time women were considered almost auxiliary in medicine, yet women worked as hard as most people, and it was never really clear, I think, that women had very often 2 jobs. 80% of us were married and had children. Yet it wasn't that common for the husbands to take part in the full family spectrum of work at that time as it is now with the younger men. And I think we focused on combining career and family a lot, on lifestyle issues, and we also focused on changing attitudes to women physicians amongst our male colleagues. In particular, I don't think we ever had real issues with the patients, but we did with the profession. A woman who worked a 46 to 50-hour week was considered a part-timer in those days, and yet your average industrial worker had a 38-hour week. So it was sort of an interesting conception or misconception of the kind of work that women put in. I recall being at an Ontario Medical Association dinner where somebody sitting next to me said, "Oh, so you're a doctor?" And I said, "Yes." And he says, "Well, it's so nice to have some of you girls so that we can get someone to do locums for us from time to time." And I was just floored because at that time I was working an 8-hour week in the operating rooms at McMaster. So those attitudes, I think, were fairly prevalent amongst physicians in general, and the Women's Issues Committee of the Ontario Medical Association started off by head-on facing some of these things in organized medicine. Now, that committee doesn't exist anymore, and some people will argue it doesn't need to exist anymore, and I hope that that is true. Others will argue that there are still issues out there. But on the whole, I think as more and more women enter medicine and go into the profession, we're hoping that these attitudes will be phased out altogether. Well, there was a huge change. I was made chief of the section of obstetric anesthesia in 1988. And obstetric anesthesia evolved from the 70s, when all you did was the odd epidural with a certain amount of drug, and usually had sort of frozen women lying there waiting for their babies to be taken out with forceps, to when I left in 1998, we had a state-of-the-art obstetric anesthesia unit at McMaster. It was a high-risk unit, so a lot of the patients that we dealt with were sick mothers. We had a very high incidence of heart disease, and we saw more mothers with heart disease, I think, at McMaster than Women's College Hospital in Toronto, for instance, where my friend Amy Rice came from. And by the time I left, we had totally changed the way we do obstetric anesthesia to patient-controlled, low-dose infusion epidurals, combined spinal epidurals were used commonly. There was a lot more patient involvement in the anesthesia, and a lot more choices were available. There was a lot more understanding of the issues and of the techniques that are available in obstetric anesthesia, and there was research going on, which is ongoing. And obstetric anesthesia is now a subspecialty of some proportion in anesthesia, and I think our unit at that time was certainly second to none in the country.